नमस्कार. आजच्या BMMच्या मेडिटेशन अँड सेल्फ केअर ग्रुपच्या या रविवारच्या कार्यक्रमात सगळ्यांचं स्वागत. आपण नेहमीप्रमाणे आधी मेडिटेशननी सुरुवात करूया आणि मग आपल्या आजच्या पाहुण्यांची ओळख करून देऊन सेशनला सुरुवात करूया. सो अंजली.
अ, नमस्कार सगळ्यांना वेलकम आजच्या सेशनमध्ये. तर आत्ताच भारतामध्ये एक ट्रॅजिक इन्सिडन्स झालेला आहे आणि अनेक न्यूज येत आहेत. तर वेन एनी सच ट्रॅजिक इन्सिडन्स हॅपन्स, वी ॲज अ ह्युमन बीइंग डू फेस मेनी इमोशन्स, मेनी थॉट्स इनसाइड अस. आणि आजचं जे मेडिटेशन आहे ते आपण कंपॅशन या सब्जेक्टवर घेणार आहोत. तर कंपॅशन इज अ क्वालिटी, म्हणजे आपल्या योगिक सायन्सेसमध्ये, वैदिक सायन्सेसमध्ये इज अ कंपॅशन इज अ क्वालिटी ऑफ अ हार्ट. लव, कंपॅशन इज अ क्वालिटी ऑफ अ हार्ट अँड देर इज लॉट ऑफ रिसर्च बीन डन ऑन कंपॅशन. तर आजचं मेडिटेशन आपण कंपॅशनवर करूयात आणि वी आर व्हेरी ग्रेटफुल टू डॉक्टर अमेय कुलकर्णी टू बी हिअर टुडे टू एज्युकेट अस ऑन द हार्ट हेल्थ. आणि त्याच्या आधी, कंपॅशन अराईज वेन टू एलिव्हिएट एनी सफरिंग. वेन देर इज एनी सफरिंग, काही पेन, डिफिकल्टी असते, तर टू एलिव्हेट दॅट सफरिंग कंपॅशन अराईज. आणि कंपॅशन हे इनर, जेव्हा इनसाईड असतं, इनसाईड आवर ओन सेल्फ, इन द इनर वर्ल्ड, माइंड बॉडीमध्ये असतं, तेव्हा त्याला इनर कंपॅशन किंवा सेल्फ कंपॅशन म्हणतात. अँड वेन वी ॲक्ट आउट ऑफ कंपॅशन इन अ वर्ल्ड, दॅट इज आउटर कंपॅशन. तर युनिव्हर्सिटी ऑफ टेक्सास ऑस्टिनच्या डॉक्टर क्रिस्टन नेफनी कंपॅशन डिफाईन केलेलं आहे ऑन अ स्केल. आणि तिने एक कंपॅशनचं मेडिटेशन जे सांगितलेलं ते आपण आज प्रॅक्टिस करूयात. तर compassion has two qualities. One is yin and yang, or it's like a tender quality of compassion where you hold things comfortably, where you accept yourself as you are, and that helps in healing yourself. And there is a fierce side of compassion where you stand up for yourself, you protect yourself, and you are ready to act in the world. So that is a fierce compassion. There are so two sides of compassion, yin and yang, or tender compassion and fierce compassion. तर we have seen tender compassion in one of the last session few months back. Today I feel that there is need to practice fierce compassion. So for, in a simple words, it can be said as, when a small baby or child is crying and a parent holds him in a very tender way, caring way, accepting himself, like holding, that is a tender compassion. And fierce compassion can be said where, like, there is need to boundary to be drawn. For example, mama bear can do anything to protect her child, or to provide food for her cubs, or to like motivate them to do right things. So that energy, mama bear energy, can be seen as a fierce compassion, whereas tender compassion is a more accepting and healing. So we will start with today's meditation. For that, please sit comfortably wherever you are. You may close your eyes, and you can take nice breaths to come inside your body. You can deeply breathe in through your nose and breathe out through the mouth. Because we are going to this as a reflective practice to invite a quality of compassion within us, we will have anchor, breath as an anchor. So being aware of your body, breathing out and breathing in and breathing out. Simple sensations of body breathing in and body breathing out. Natural breathing. Breathing in, bringing in awareness inside the body. Breathing out, resting into awareness. So, anytime in this meditation, you need to have a break. You can feel these sensations of body breathing in and body breathing out. We'll start with a reflective practice. For that, invitation is to think of a situation in your life where you feel need to protect yourself or a need to draw boundaries or to stand up for yourself. We are invoking a suffering situation. Remember to have a situation in a moderate area so that we can learn how to invoke compassion within us. Call up the situation in your mind's eye. What's happening? What's going on? And instead of how and why questions, try to be with the hurt or harm that is causing. And allow yourself to feel whatever emotions are rising in you. It could be fear, it could be anger, it could be frustration, or it could be any emotion. You can come in contact with any physical discomfort that this emotion may have caused inside your body. You can scan your body for any physical discomfort that might be happening in the body, physical sensation. And now we are going to bring in three components of self compassion so that we can protect ourselves as need be. First, you can slowly say to yourself, I clearly see the truth of what's happening. This is mindfulness, where we clearly see things as they are. Other phrases you might say to yourself is, this is not okay, I can see that. Or this is unfair, this is not safe. Later we can move on the second component. I do not stand alone, I stand with others. This is common humanity. We draw strength from our brothers and sisters to stand up for what's right. Other phrases you can think of is, all human beings deserve just treatment. Or I am not a victim, I am empowered. Now, invitation is to make a fist of one hand and put it over your heart as a gesture of strength and power. I will protect myself. This is self kindness instead of abandoning, getting angry and fear. This is a kindness to be safe, to protect myself. In our fierce compassion, it is our commitment to draw boundaries and prevent harm. Other phrases that you can say are, I will not yield, or just stop. I will take whatever is needed Action is needed, necessary to prevent this. If you are having difficulty to find right words, you can think of a close friend who is facing such situation, and you can think of words that you will say to this friend. And now, can you offer the same message to yourself? Finally, putting your other hand over your fist and holding it tenderly. The invitation is to combine the fierce, compassionate energy, fierce, empowered clarity with tender energy of compassion, loving, connected presence of tender energy of compassion. Giving yourself full permission to feel the force of fierce energy, your anger, your resolve, your truth, but to also feel the love. Aiming your fierce compassion at the harm or injustice is itself, not at any person causing the harm, but towards the harm or injustice. You can allow to feel your fierce energy while still keeping the thread of love alive. See if you can allow both energies to flow, to mingle with each other. And letting go of this reflective exercise, getting connected with sensations of body breathing in, body breathing out, getting awareness to your body, and slowly opening your eyes. Thank you very much for practicing this compassionate exercise with me. If you have any questions regarding this exercise, you may ask in group later on. And now I request Saili to introduce our guest speaker, Dr. Ameya Kulkarni. Thank you.
Thank you, Anjali. I think we all needed this exercise today morning. Thank you very much. After providing this compassion and love to ourselves and our heart, we are now going to learn more about physically how to take care of our heart. Dr. Ameya Kulkarni is here. Thank you very much, Dr. Kulkarni. I'm going to read out a short introduction. Uh, so let's welcome Dr. Ameya Kulkarni, a distinguished interventional cardiologist and associate medical director at Kaiser Permanente in the Mid-Atlantic region. Dr. Kulkarni earned his medical degree from Yale University, his residency at Columbia University, and pursued fellowships at both Mass General Hospital and University of California, San Francisco. He is board certified in internal medicine, cardiovascular disease, and interventional cardiology. Beyond his clinical expertise, he is deeply committed to community health and currently serves as the president of the American Heart Association's Greater Washington Region Board of Directors, where he advocates for initiatives like expanding CPR education and promoting heart healthy lifestyles. We are really honored to have you here with us today, and we are looking forward to hearing your insights and experiences. So, off to you.
Thank you so much for having me, and it's really delightful to be here talking to all of you. I'm just going to share my screen. I just want to make sure you can see my screen here.
Yes, yeah.
Great, wonderful. Before I get started, I want to say, thank you for reading my bio, but there's a couple of parts on my bio that I think it's important for this group to hear about. So my father is Baba Punatsahe, Hai Nagpurchi. And one of my scholarships for college was a Marathi Vishwa scholarship, and so my my connection to our community runs very deep, and so I was really honored to have the chance to speak to you all because you are my family, right? And so I really thank you for the chance to talk to you about heart health because I'm here where I am today because of our community. So I'm grateful for the chance to give back a little bit. I also really like the meditation on compassion for yourself. In cardiology, I often talk to people who have recently had a heart attack or a major cardiovascular condition, and their first instinct is to blame themselves. What could I have done differently? And I think that one of the first things I often say is to give yourself grace because some component of what you have is in your control and some is not. And giving yourself grace for the things that are not in your control is really important. So I think it's a very timely meditation. So thank you for that. All right. So I'm going to talk a little bit about heart disease today. And what I'm hoping to do, slide on. There you go. What I'm hoping to do is talk a little bit about what heart disease is, because people often ask about heart disease. So I'm going to bucket it into some categories. Some of the tools that we use to evaluate heart disease, what you can do to minimize your risk, what symptoms should concern you, and then a little bit about GLP-1s, because I think everyone is asking about them. So I'd like to just talk about the data behind it and how one should think about GLP-1 receptor agonists like Ozempic in the context of heart health. And these two lovely young ladies here, these are my two daughters. This is Layla, the older one, and Ariana, the younger one. This was at our annual Heart Walk for the American Heart Association. So, all right. So let's talk a little bit about buckets of heart disease. Now, people often think about heart disease as one big thing, but it's actually several things. So there's one category, I think that's what we mostly think about when we think about heart disease, which is coronary artery disease. And the way to think about that is that the coronary arteries are the fuel lines for the body. They're the things that get oxygen to the heart muscle that allow the heart muscle to do its work. And so when somebody talks about having angina or have had a heart attack or in cardiogenic shock or have coronary artery disease, all that is in the category of the plumbing. It's the fuel lines getting to the heart muscle. There's also other types of heart disease. There's something called electrical heart disease, so atrial fibrillation or supraventricular tachycardia. These are electrical conditions that affect, as the electricity of the heart is what drives how the heart squeezes. But they're separate from this sort of the heart attack conditions that we talked about. There's a third category that has to do with the valves. So inside the chambers of the heart, there's valves between each chamber. So if the valves have issues, whether due to infection or just life or genetics, then you can have issues with the valves. And then the fourth category is what we call heart failure. And that's where the heart pump itself stops working or works less well than it did before. That can happen for a variety of reasons. And that's sort of a fourth bucket of disease. For this talk, the things that I think are most relevant to most people is that first category that I talked about, coronary artery disease. So I'm really going to focus the attention in this talk on coronary artery disease. So let's talk about what coronary artery disease is, or coronary arteries are first. So as I mentioned, coronary arteries are the fuel lines that go to the heart. So you can see there are three labeled arteries here: the left anterior descending, the circumflex, and the right coronary artery. And these are three arteries that give blood to the entire heart. The way to think about it is the heart is the engine that squeezes blood to the rest of the body. So blood and therefore oxygen that the blood carries can get to the whole body. The coronary arteries are the fuel lines for the heart muscle itself. So if you have a blockage in one of the coronary arteries, as you can see in this image here, if you get a blockage in one of the arteries and now no more blood is flowing to that heart muscle, that means oxygen can't get to that heart muscle. And if oxygen can't get to that heart muscle, that part of the heart muscle over time can die. The cells can die in it. And once it dies, then a scar forms there and it can't squeeze anymore. So it can't pump the blood it needs to get to the rest of the body. So that's actually the problem that we see in coronary artery disease. Now, there's actually two flavors of coronary artery disease. There's one that I call the angina pathway, and one that is the infarction or the heart attack pathway. And most people think that those are the same thing, that they're sort of on a spectrum of disease. And I hope in the next 5 minutes, I'm going to share with you sort of the biology of both of those things so that you can see how they're different from each other. So let's start with what happens in stable angina. So stable angina starts on the frame in the far left. You can see that there's blood flowing through the coronary artery. And then there's three layers of the coronary artery here. There's the endothelial layer, there's the intima behind it, then the media, and then the adventitia. And what happens happens to us all the time, it started happening in your 20s, is that you get a little damage to the endothelial layer. This can be because of shear stress. It can be just because of things like air pollution or smoking, high blood pressure. Something creates damage to happen to the inner vessel. And in the repair process, as the body repairs that, you get to that second frame here, which is where you can see that plaque form. So what happens is in the repair process, the body puts layers of calcium and cholesterol, we call that a plaque, between that intima, that endothelial layer, and that media. So then you get this thickening here of cholesterol and calcium. And for most of the time, the body's pretty good at adapting to that. But over time, if that plaque grows, like you see in the third frame here, the vessel narrows. And so just like it's just like in plumbing, if the vessel narrows to a degree where the heart can't get enough blood cells with oxygen across when you need it, then the heart muscle doesn't get enough oxygen at certain times, and then you can feel the effects of that. So typically when we see angina, first place you feel it is when you're exercising, because when you're exercising, the heart has to work harder to get oxygen to the rest of the body, so it needs more oxygen itself. And so then at rest, you can usually tolerate this narrowing, but then when you're exerting yourself, you can't get enough oxygen to your heart muscle to work, and so then you can get chest pain on exertion. So that's actually what stable angina is. And if this starts getting narrower and narrower, it takes less and less exertion to get to sort of get the symptoms, and then you get worsening and worsening angina. So that's one condition. What happens in a heart attack is something slightly different. What happens in a heart attack is that this endothelial layer, you can see in the third thing on the right here, the endothelial layer actually ruptures. And when it ruptures, the stuff inside the plaque comes into the blood vessel. And then the body thinks that stuff that's coming from the plaque, that calcium and cholesterol leaking into the blood vessel, is actually a foreign body. And so it responds by forming a clot. And that clot stops all blood flow coming to through the vessel, and then you have a heart attack. You have a sudden loss of oxygen to the heart muscle, and you get a heart attack. So that's actually the process by which a heart attack happens. Now, interestingly, and typically if I did this presentation in person, I would ask as a survey, but you can do it in your own home and you can guess which one is more likely to rupture and cause a heart attack, a 10% blockage or a 90% blockage. It's actually it's actually about the same. There's no difference in the risk of this rupturing from this rupturing, because what causes the rupture is actually the thickness of the endothelium and the composition of the plaque. And those two things can be similar at 10% blockages and at 90% blockages. And so whether you have a 10% blockage like this one in the middle over here, or a 90% blockage like this one on the far right here, the risk of rupture is the same. So the risk of heart attack is the same. Now that's important as we sort of think about how we are going to evaluate somebody who we're thinking about has this type of coronary artery disease. So the first place we start with is symptoms. So if you come to see a cardiologist because you're noticing some symptoms on exertion, you're having chest pain when you walk, or you're noticing that I used to be able to walk all the way around the block without stopping, and now I'm only walking halfway before I have to stop to rest. Those are symptoms. And when you have those symptoms, in my head as a cardiologist, what I'm thinking is you may have stable angina. And if I want to understand whether you have stable angina or not, what I want to do is a test to understand whether you have stable angina or not. And the easiest test to do is actually a stress test. And I'll tell you that in the community, a lot of folks like to do what's called a nuclear stress test, where we put you on a treadmill and then we inject an agent into your blood so that we can light up the heart muscle and see what parts are getting oxygen or not. I'm an old school doc, and so I actually like the treadmill stress test the best. And the reason is because a treadmill stress test by itself gives us a ton of information about what symptoms you're having when you exert yourself, because it's a standardized way of exercising that I can know, okay, you have those symptoms now at 8 minutes into the stress test, and if I adjust your medications and then I put you on a stress test again, I can see, gosh, it was 11 minutes before you had the stress test, or now it's getting worse. And so it's a really objective assessment of exercise capacity, which is really useful. But a stress test can be a nuclear stress test, can be a treadmill stress test, can be what's called a stress echo. And then we have a bunch of tools that we can use in the cath lab to understand whether or not the heart muscle is getting enough blood with exertion without having you exert yourself, using some clever tools once we get you into to get an angiogram. So that's the assessment of symptoms. Now people ask, well, how do I know if I'm going to have a heart attack? So interestingly, while we have a lot of tools and are very good at understanding when somebody has symptoms, whether those symptoms are related to coronary artery disease or not, we actually we haven't evolved a lot in the tools that we have to predict the risk of a heart attack. And that's not because we haven't tried. I think there's been probably $1 trillion spent on trying to understand, who is going to have a heart attack or not. It's just that it's actually really hard to predict because of what I told you before about that 10% and 90%. The way that a plaque looks on an angiogram or a CT scan, it doesn't help us understand better which plaque is vulnerable to rupture and which is not. So to date, the sort of Framingham risk study, which was a study that was started in the 60s in a town outside Boston called Framingham, that had some risk factors that predicted risk of heart attack. We have some modern versions of that, but pretty much those factors are still the same factors we use to understand risk. And they're actually pretty good at predicting risk within some boundaries. We've had a lot of new types of testing that has tried to come out there. You probably have heard about microparticle analyses, where we take your lipid panel and then we sort of look at every little microparticle. There's something called calcium scoring, which I'm going to talk about in a little bit. That sort of has helped us predict risk at all a little bit. But unfortunately, all these have sort of marginally improved our ability to understand risk. But what they haven't done is told us what to do. Because whether you have a really, really high calcium score, or your lipo-A is very high, or the ratios are all off, or all these things that sort of help us understand risk better, the answer on how to solve these hasn't changed at all, because it's the same tools we've always had to try to reduce your risk maximally, which I'm going to talk about in a second. So now, I promised I'm going to spend a minute and talk about calcium scoring, because I think that's something that people ask a lot about. So for those of you who don't know, calcium scoring is a test where you get a simple CT scan of your chest. And on that simple CT scan, a radiologist or a cardiologist can go and actually count the calcium on your heart arteries and give you a number called a calcium score. Now, it's important to know that the calcium on your heart arteries, more than 90% of that calcium is outside your heart arteries. And so some people think that when you're getting a calcium score, it's telling you whether you have blockages in the heart arteries or not. It's actually not. It tells you nothing about blockages in the heart arteries or not. What it's doing is it's counting the calcium all around the heart arteries, because we know that vessels that have more calcium around the heart arteries are likely to have more plaque. Now, there's a couple of caveats to this. In South Asians, the calcium score is somewhat predictive, especially in young South Asian men. So I mean 40 to say young because I'm in my 40s, so we're going to say that's young South Asian men. In young South Asian men, the likelihood of calcium score predicting coronary disease or risk of heart attack is is low. About 33% of people with a heart attack who have had a calcium score before, if they're South Asian men, have a calcium score of 0. So it's not as predictive in young South Asian men, in young people in general. It's more predictive using classic risk factors. So people who have smoked or had exposure to air pollution, it predicts their risk much better. In the sort of the folks who have high cholesterol or diabetes, predicting their risk, it's less useful. So there's some nuances to calcium scoring. The things it does not do, it does not tell you whether you have coronary disease or not. It's a predictor of risk, not a predictor of disease. And the other thing it does not do is it doesn't tell you whether the therapies are working or not. I've seen some cardiologists in the community who say someone should get a calcium score every year or every 2 years. That's complete nonsense. It does not, the change in calcium doesn't tell you anything about the change in risk. What we know is it gives us an initial estimation of risk, but then it doesn't, the changes don't tell us anything. All right, so that is calcium scoring and prediction of heart attack in general. So now what do we do? Now that we know that what our risk is, because we have thought about our weight, our smoking status, our cholesterol level, our blood pressure, our genetic history, and our age. So we have a sense of what our risk is. So what do we do to solve for that risk? Well, it's actually this, like I said, it's the same things that have been true for 40, 45 years. Diet, exercise, check and treat your blood pressure, check and treat your lipids, and stress reduction. These 5 things are sort of the pillars of primary preventative cardiology and have been for, I think as long as I've known about cardiology. I'd like to talk about some specific things in some of these elements that are applicable to South Asians that I think will be useful. The first one's on diet. So we talk a lot about what you can do for diet to reduce your risk of cardiovascular disease. And there's lots of things you can do. Certainly, if you reduce the total number of calories you eat, that's probably useful. If you flip to having more than 50% fruits and vegetables in your diet, that's definitely useful. But in South Asians in particular, I think this study is very interesting. This study is now almost 8 years old. It looked at 18 countries. It's called the PURE trial. It looked at food intake and disease patterns in 18 different countries, the largest observational study ever done in nutritional research. And what it found specifically in India was that if you change the percentage of carbohydrates that you eat from over 60% to under 50%. So on average, if you reduced your carbohydrate intake by more than 10%, you had a meaningful reduction in your risk of cardiovascular disease and death that was similar to quitting smoking. So it's a pretty substantial benefit to reducing carbohydrates. And that, by the way, that effect went all the way down to you got, I think, about 20 to 25% of your calories from the carbohydrates. And so a lower carbohydrate diet, in particular in folks of Indian origin, is very helpful in reducing risk. And so what that means for us is we have to think about rice and roti, right? Like those are the two things we should be thinking about, because those are the things that have the most carbohydrates. And thinking about how to reduce them as a percentage of our total calories is a way that we can modify this. All right, so diet is one thing, exercise is another. Cardiologists always talk about exercise as being important for reducing your risk of heart attack. The way that I put it is that that exercise is, you can never outrun your genetics, but you can run away from them pretty easily with exercise. And this is a great graph to show sort of the effect of exercise on your risk of heart disease. So if you look on this graph, this was a study that's now, I think, almost 20 years old. And it compared people who had no exercise and saw like what their risk of dying was if they just increased exercise to walking the equivalent of about 10 minutes a day. And you can see that from no exercise to walking 10 minutes a day, it cut in half their risk of death. Now, again, this is the same change in risk as quitting smoking. So it's a pretty substantial benefit to exercising. And you can see that the more you exercise, the more benefit you get from exercise when it comes to heart disease. But I'd say that that if you're not doing anything now, just starting with something is useful. Even if you just have one of your iWatches or you have a watch that measures your steps and you want to get from 2,000 steps to 5,000 steps to 10,000 steps, I think that every incremental increase in the amount that you're active is useful. And the nice thing is the American Heart Association has actually done a bunch of studies on this that show that even if you're not exercising in a concentrated fashion, so in other words, if you don't have time to go to the gym and work out for an hour, if you find 5 minutes in the morning, 10 minutes at lunchtime, 10 minutes in the evening, and cobble together 30 minutes in a day, that is actually also pretty useful. So any amount of exercise that you can find is great. Now, even if you don't have any time to exercise at all, if you just make the decision to park far from the restaurant or the grocery store instead of close to the restaurant or the grocery store, and just decide to do that walk every time, that's a little bit of exercise as well. And you'll find that even if you can do nothing at the moment, just adding a little bit of exercise into your day every day, you'll start to get better and better at it. And then over time, you'll be able to do more. So that's exercise. Blood pressure control is something we talk about all the time. It's probably one of the best studied risk factors for cardiovascular disease ever. And no matter what the study looks at, anytime you can meaningfully reduce someone's blood pressure, you're reducing the risk of heart attack, stroke, and death. And in this was a meta-analysis which sort of took a bunch of studies and put them together, and shows that a 10 millimeter mercury reduction in systolic blood pressure was associated with a 13% lower risk of death. So every time you're reducing if you were to linearize it, you'd say for every 1 point in blood pressure you reduce, you're reducing your risk of death by 1% on average. And so it's a pretty substantial benefit for blood pressure control. Now, one thing that I want to say about blood pressure control that goes back to that grace for yourself conversation that I want to have. There absolutely are parts of blood pressure control that are in our control. The amount of salt that we intake, the amount of exercise that we do, whether we smoke or not, all those things can increase our blood pressure. But there are some things that are not in our control. There is a genetic component to high blood pressure that's just not in our control. And so I wouldn't view, if you have to be on medications for blood pressure, I wouldn't view that as a surrender to medications. Sometimes that's just what you need to reduce the risk. And some of those things are just not in our control. So giving yourself the grace to sort of say, I'm going to control the things that I can, and for the things that I can't, I'm going to use these medications that have a lot of value. I think that that's a great way to think about blood pressure. In the same vein, thinking about diabetes has a massive effect on a risk of heart attack and stroke, primarily through the mechanisms that I showed you at the beginning. So that endothelial dysfunction process in people who have diabetes, that endothelial dysfunction gets worse and more frequent. So your blood vessels are constantly damaging and repairing themselves at a higher rate than people who have uncontrolled diabetes, those who don't. And so again, if we are able to improve your diabetes, we're able to reduce your risk of having a heart attack or stroke. The study that I've had here is about the use of statins in the reduction of heart attack and stroke. And this study is in particular in diabetics, but I think that it works across the board. People sometimes ask me, do statins really work in reducing your risk of a heart attack? Or is it going to cause things like people are worried about it causing dementia or inducing diabetes? I'll tell you that diabetes and dementia are diseases of aging. So anytime you see somebody saying a specific medicine over 20 years is associated with those two things, it's likely just a phenomenon in the epidemiology rather than a true effect. And the more rigorous studies have demonstrated no link between statin use and any of those things. And statins work in reducing your risk of having a heart attack. On average, if you've had a heart attack already or had a stent or had bypass surgery, it reduces your risk of death at 2 years by 33%. That's one of the most substantial mortality reduction risks we have ever seen, 33% risk. If you've never had a heart attack or stent or bypass surgery, your risk reduction, depending on who you are, is somewhere between 3% and 8% per year. So still a pretty substantial risk reduction, but not as much as if you've had it. All right, so what symptoms should worry you? If you get symptoms with exertion or you notice a change in your exercise tolerance, I think that that's the earliest sign that the engine for the body is having some issue. And, it may be lots of reasons why you're noticing that you're more tired when you're walking or that you're getting chest pain or shortness of breath when you're walking. But it's worthwhile having a conversation with your doctor about it just to sort of evaluate it. I have these conversations almost every day with somebody who is worried about some symptoms with exertion. So we have a lot of ability to understand what is cardiac and what is not. But having that conversation is really important. The other thing that sometimes people say, all of a sudden, I never took a nap before, and now I take one every day. Or I used to, be able to have energy after lunchtime, and now I just need to sit on the couch. If you notice that consistently you have a sudden change in your ability to get through the day, that's a conversation you should have with your primary care doctor. And the last one is super important because I can't tell you how much heart disease I've caught by ignoring what the husband says and listening to the wife. Because the people around you often notice things about you that you don't notice. And so if one of your loved ones is saying, you just don't look right, or I feel like you're more tired than you have been, don't ignore that. Have that conversation with your primary care doctor because it's often a very sensitive sign that something has changed. All right, so I'm going to spend 1 minute talking about GLP-1 receptor agonists because I think lots of people ask about it, and then we can, the most of the time I'd love to save for questions if you have. So first, what is a GLP-1 receptor agonist? The simplest way to describe what a GLP-1 receptor agonist is, so GLP-1 is this enzyme that sits in your stomach that manages how your stomach releases and holds on to insulin. And so what happens when you eat is that your stomach releases, convinces your body to release more insulin because it knows food is coming. The speed at which the insulin releases and is broken down tells you when you are full. And so basically what GLP-1 does is it triggers satiety and makes your brain think that you're full. And what a GLP-1 receptor agonist does, it's a medication that artificially early tells your brain that your body is full. So you eat less, and as a result, you lose weight. And I got to tell you, the last 10 years has been full of very pretty significant changes in revolutions in medicine, I'd say. GLP-1 receptor agonists are probably the biggest revolution in medication I've ever seen. They are meaningfully going to change, I think, how healthy people become. The data is just really remarkable. And here's what the data is. This is for all comers. This one is for diabetic patients. Reduces the risk of death by 12%. No changes in safety outcomes for cancers or other things. Improves kidney health. Reduces the risk of heart failure. Reduces risk of adverse cardiovascular events. It's a really remarkable change. And then even in patients who are not diabetic, this is from the New England Journal of Medicine. People who have a BMI over 27. There's a pretty significant reduction. You can look on the bottom right corner, death from any cause, death from cardiovascular cause. These are all statistically significant reductions. And so I would say that in a big chunk of the population, people with a BMI over 27 or diabetics who are not under control with basic medications, medications like Ozempic or Wegovy have a real opportunity to change outcomes. And so I think it's going to be interesting to see once the pricing on these medications becomes in a more reasonable range. They're going to be like statins. Everyone's going to take them. Now, they're not a panacea, because it does create early satiety. It means that you lose protein as well as losing the fat. And so you should be worried about muscle mass reduction with these medications. And we also, they're relatively new. And so sometimes it takes us 10, 15, or 20 years to understand what the true effects of these medicines are. But at least right now, they seem to be a pretty significant change in the care of patients with cardiovascular disease. All right, so that is my last slide. What I'm going to do is I'm going to stop sharing because it looks like there are some questions coming through, and I would love to answer the
Yeah.
questions.
So thank you so much, Ameya. And, we definitely have questions. But before that, I would like to start with one question which I believe is on everybody's mind, especially given the South Asian community, where, we have all these symptoms, whether it's related to our chronic diseases, but we don't give attention to it, right? You mentioned in your presentation as well. And, there are people, whether it's men or women or both, who maybe they don't have some of the typical symptoms associated with heart disease or heart attack, like they don't get chest pain, but they might experience, breathlessness or shortness of breath or jaw pain, back pain, left arm pain, or maybe the chest pain after eating, some of these symptoms. So what is something that A, we should look for, and B, what should we do about it if in terms of heart health?
So a couple of things. I think that there's a couple of questions. First is the type of symptoms that people have, and then second is what you should look for. So in terms of the type of symptoms that people have, it is true it is true that some people have atypical symptoms. They can have jaw pain, left arm pain, stomach pain with ischemic heart disease. However, in men, about 2/3 of symptoms are traditional, and in women, about 56% are traditional. So it's still more than half of women who have ischemic heart disease are going to present with that classic chest pain. What I would say is that two things. What I would say: one, the easiest way to figure out whether something is ischemic or not, something's related to your heart arteries or not, is to see whether it gets worse with exertion. So if symptoms that get worse with exertion or change your ability to exert yourself should raise your level of suspicion. If there are things that don't change with exertion and you are not changing your habits because of them, then it's not something to worry about. So sometimes people will say, well, I didn't have any symptoms with exertion, but then when you ask what they did for exertion, they said nothing. And so then, of course, you don't have any change with exertion. The simplest way, by the way, to have a stress test as frequently as possible is to do the same walk once a week at least. So do a walk where at the end you feel a little bit tired, 20 to 30 minutes every week. And that will be your stress test. If you notice a change in your ability to do that distance, or how far you can go, how fast you can go, how tired you feel at the end, that's the earliest signal that something's going on. The other part is, I think people sometimes think that testing is the only way to figure out whether something is cardiac or non-cardiac. Honestly, the most important thing you can do when you have a symptom you're not sure about is to talk to the doctor that you trust about it, because what I do when I see my patients is every time I see them, I'm filing away the symptoms that they're telling me into this sort of Rolodex of symptoms that they have. So what I'm thinking is, for you in particular, when you eat, you get this, I'm not worried about that. But when you have this other symptom, it's something that's worrisome to me. So even telling us about the symptoms that you're worried about that are not cardiac is useful for me, because then I can file them into a Rolodex in my mind. And so I think that we're sort of trying to paint this picture of what is cardiac and not. Best way to do that is to have a couple conversations with cardiologists.
Great. So there are quite a few questions about going to the doctor for certain things.
Yeah.
So, and South Asians, as South Asians going to a cardiologist in this country, if that cardiologist is not familiar with how to look at South Asians in particular, it might be difficult. So my question to you is it a good idea to make sure that they are taking into consideration that you are of South Asian descent? And also somebody has said, do you recommend people over 65, 70 go to cardiologist even if they don't have symptoms, just to get tested?
So let me answer the first question first, and then the second question. So I think that most doctors now know about the risk to the diaspora. So I think that risk is pretty well established. Now, the good news is what we think the majority of the factors that are contributing to heart disease in South Asians, they're non-genetic. The majority of them are not, they're lifestyle related. What we think is it's a combination of two things. It's our genetic background in the context of the exposures that we have to things like foods, cholesterol, and things like that. There are a couple of things, I think, in the largest study ever done on South Asians is a study called the Masala study. It's an awesome longitudinal observational study that has looked at South Asians in a variety of ways. And it turns out that 99% of the things that they have found are things that are true both for South Asians and non-South Asians. So if you're paying attention to your blood pressure, your cholesterol, your the diabetes risk, your BMI, et cetera, diet, exercise, you're sort of capturing 99% of it. There's two things that I think that are distinct that probably are worth mentioning. So one is the BMI targets. It does seem that our risk of heart disease goes higher at lower weights. And I'm not sure it's because of our bone density or because of our average size, but for South Asians, for example, they say like 23, 23.5, maybe tipping into the overweight scale for BMI. So we need to think about weight differently than others. And then the second is the effect of carbohydrates on us. And so that study, the pure study that I told you about that looked at 18 different countries, the carbohydrate effect was most pronounced in Indians and in Koreans. Yeah. And so in those two populations, I think we should be thinking about carbohydrates differently than others. More important than, by the way, seeing a cardiologist or primary care doctor who knows South Asian health is to see a nutritionist who knows. So, because that's actually the most important. Yes. It's like if you can go see a nutritionist who knows South Asian diets and can modify their recommendations for your diet, that is way more valuable than seeing me. So
yes, and that's true for many chronic diseases. If we can 100%. Find somebody who can talk to us about our specific diet, yeah, that will make a big difference. So one related question that is here from Supriya, she says, many of my friends and spouse were not given GLP-1 even after asking. Some of them have over 30 BMI. So what can be done to get GLP-1 coverage in pre-diabetic patients? And I've heard this a lot. So
I will answer that in 1 minute. I forgot to answer your other question about the cardiologist. Did you say, should we see a cardiologist for preventing Sulava? Yeah. So I don't think you should see a cardiologist unless you have symptoms. I think your primary care doctor should be the center of your primary prevention journey. And the reason is because primary prevention is not just about the heart, right? Because they're all these, like, it's diabetes, it's brain health, it's musculoskeletal health, and they all interact with each other. You need a quarterback. So your primary care doctor should be your quarterback who sort of manages everything. And then they should ask for help as they think is necessary. Seeing me, just so I can tell you the things that I told you on this talk, would make me feel good, but it's not necessarily useful. Because I'm only telling you about your heart health, and then somebody's going to tell you about your brain health and your musculoskeletal health, and you need somebody to sort of balance all of those conversations. So we're not asking you to do insane things at once. And that's, by the way, what happens in, my system is integrated. So we actually have a primary care doctor at the center of this conversation to make sure that doesn't happen. But in fragmented medicine, your cardiologist tells you one thing, your nephrologist tells you something completely different. Your orthopedic surgeon says, don't walk, your neurologist says, walk more. And so you need somebody to organize that. And so I'd say that you don't need to see a cardiologist, you need to see a good primary care doctor. Now, let me talk about GLP-1s in the context of insurance coverage. I would say that most insurance companies are struggling with the cost of GLP-1s. I think that if every single person who was indicated for a GLP-1 got a GLP-1, it would bankrupt the system or make your premiums impossible. We would not be able to afford medicine at all. So there's two options, I think, for GLP-1. So one, most systems actually have a comprehensive weight loss center. So my program has a comprehensive weight loss program. So if you're a Kaiser patient in the Mid-Atlantic and you're interested in weight loss, we put you through the comprehensive weight loss program where you start with diet and exercise, and we talk about whether it makes sense to do gastric bypass or whether it makes sense to give you a GLP-1 or, it's not just the one, and there's actually other medications. GLP-1s are one medication, but there's a bunch of other medications that actually are effective at weight loss as well. And so what I would say is rather than thinking of, I need GLP-1s now because that's what the thing that everyone's getting, think about it in the context of everything else. The second thing that I'll say is that most physicians, if you qualify, are willing to prescribe it. It's not a prescription issue, it's a payment issue. So you can always pay out of pocket for it. And things like Cost Plus is a pharmacy that can, and there were the compounding pharmacies that were charging a lot less for it. So when it comes down to this is sort of it's a coverage question rather than a benefit question. I think nobody disagrees that this medication has a lot of value. It's just that we gave every obese person GLP-1 inhibitors, then that's the only medicine we could spend money on. So, yeah.
Yeah. No, that's really good. I think you covered all aspects of that question.
Yeah.
So there are a couple of questions about statin use, and we always get that kind of question. So Jyotsna asked, should one take statin for high LDL without having high BP or diabetes?
Yeah. Great question. So what I'd say is every conversation is individualized, but the way that I would think about it is we start by determining a risk score. So what is your risk of developing heart disease in the next 10 years? And so that there's a couple of available risk scores for this. One is called the ACVSD risk score. And if your risk is over 5% in the next 10 years of developing heart disease and you have an elevated LDL, you should definitely be on a statin. And so a lot of it depends on your individual risk factors. Every primary care doctor in America knows how to calculate an ACVSD risk score. So I would say the next time you see your doctor, ask what your risk score is, and then based on that, do a statin. The one exception I think that we should consider is that is in the calcium scoring. And so I saw my auntie Malini just asked about the calcium scoring. If you have a calcium score over 100, that is the equivalent of having that sort of over 5% risk according to the risk factor. So I would say if you have an elevated calcium score and you're concerned about your risk of heart disease, that's an appropriate place to take a statin, even at lower LDL levels. And so those are the two things: so calcium score or risk, ACVSD risk over 5%.
Okay. And there are a couple of questions about calcium score as well.
Yeah.
Can calcium supplement accumulate on arteries and increase calcium score?
So I love this question. So the short answer is no. Your body's really good at regulating calcium intake and output. So if you took too much calcium, you would excrete it out. So that's not usually the cause of calcium accumulation at normal levels. Sometimes people have a disease of their parathyroid where they accumulate calcium very rapidly and your body can't excrete it. But like for the average person taking calcium supplements, your body will just get rid of the excess. The calcium that builds up on your arteries is from that breakdown, that endothelial dysfunction and repair process.
Okay. And I had one question. So South Asians often have normal LDL but low HDL. So
Yeah.
should we check for lipoprotein A and B in that case?
Right. So there's two questions encompassed in there. So low HDL, HDL below 40, historically has been associated with a higher risk of heart attack and stroke. There are two things that can increase your HDL that also reduce your risk. So one is genetics, so you can't control genetics, and two is cardiovascular exercise. If you do more than 150 minutes of cardiovascular exercise where you get your heart rate more than 30% above its baseline, then you will definitely improve your HDLs and reduce your risk. So HDL is separate. So the small particle lipoproteins in people who have normal LDLs can be useful in helping us understand risk. And for someone who otherwise doesn't need a statin, like if your LDL is 100, but you have two first-degree relatives, your father and your brother died of a heart attack before the age of 50, then your risk is high enough where I don't actually care what your microparticles are. I'm going to start you on a statin no matter what. But if you're sort of in the low to moderate risk range and your LDL is low, and there's something about your risk that makes you worry about, then doing microparticles may help us understand whether you may benefit from a statin anyway. Now, there's a caveat to this. There's never actually been a study done to look at treating lipoprotein A with a statin and outcomes. So we actually don't know whether it works or not. And cholesterol is very complicated. So, for example, there was a medicine called niacin that increased HDL. For a long time, we thought this was going to be the panacea. It's going to be a medicine that improves outcomes. But it actually increased risk of death in one study. And so it's not clear that just because we changed the number, we changed the risk. With that said, there does appear to be a treatment for lipoprotein A that's specific to lipoprotein A, and the initial studies seem to be very promising. So I think in the next 3 years, this will be a very different conversation. We likely will be checking microparticles in Google. But it's still about, like, I want to say it's like 3 years away. The study just came out this year that was very promising, but I think they have to do one more phase.
Okay, great. We have a few more minutes to take some questions. So one question that Ashatai asked, what is heart murmur? And I think she says, I'm surprised to know that the calcification in right breast could be seen as part of any arterial calcification. Sorry, I didn't get the question, but can you talk a little bit about heart murmur?
Yeah, so heart murmurs, the way to think about heart murmurs is when the blood flows through the heart, if it goes through a high resistance system, then it will make a sound because of the agitation created by the high resistance that we can hear with the stethoscope. That's a murmur. The most common cause of a murmur is what we call flow. So the blood is flowing faster through the heart than normal, and it creates a vibration that causes a murmur. Sometimes like a valve condition of aortic valve disease, mitral valve disease can also cause a murmur, but it is, if your doctor hears a murmur, there's a pathway we go down based on what the murmur is. But the simplest way to think about it is it's just rattling of the blood through the heart based on the speed it's going. And then the calcification of the right breast could be seen for any part of aortic calcification. So breast calcification is different than coronary artery calcification.
All right, sir. Thank you.
It's in the same place, because it's left chest, left breast, but they're two separate things. They're not related to each other. They don't predict the risk of one another. So
I'm going to take one more question from the chat. A couple of people have asked about low carb diet for Indian vegetarians, or which cooking oil do you recommend for Indian cooking? Very commonly asked questions.
Very commonly asked questions. So, the best data on which cooking oil to use is to use olive oil, because olive oil has the highest number of polyunsaturated fatty acids, and so would be the best oil to use. Unfortunately, it's got a low smoke point. So for our Indian cooking, it's not always the best. And some people will say it adds a flavor to the food. Though I think that at this point, most people using olive oil for years now, and you get used to it, just like anything else. Avocado oil is actually reasonable to use as well. Same idea, has polyunsaturated fatty acids. So the key thing is, the way to think about it is that there's good fats and bad fats. The best fats are what we call polyunsaturated fatty acids. The second best are monounsaturated fatty acids, and then the bad ones are saturated fatty acids and trans fat. The worst oils to use for vegetarian cooking is coconut oil. Don't use coconut oil. Worst oil to use, all trans fats. And it's funny because there's all this like Facebook lore about coconut oil being a good or positive or the worst oil to use. It is like just as bad. You might as well be cooking in pork lard. It's just as bad, but don't use that. But avocado oil and olive oil are the two best ones. And in moderation, like if you're just using it once in a while to make some puris for your grandchildren, like, and you're gonna have some as well, like that, it's okay to use the oils you use, canola or vegetable, or once in a while is okay. If you're for everyday cooking though, olive oil or avocado oil.
And how about ghee?
Oh, the worst. Ghee is the worst. Don't use it. Throw it out. Don't use it ever again. So ghee is clarified butter. And so when you clarify butter, all you're leaving is the trans fat, literally the worst fats for atherogenesis. It is absolutely horrible for you. If you never use ghee again, you will be better off for it.
Okay. Manjiri, you want to ask a question?
Yes, I do. Can you hear me?
Yes.
Okay. My question is, if you can go to your slide 2,
Okay.
that has that picture of arteries.
Yeah.
You see the third picture
Yeah.
that has more yellow than the second
Yeah.
picture. I wanted to understand the mechanics of how that yellow gets reduced. And I'll give you a little bit background. Both my LDL and HDL were high 2 years ago. I made a complete change in diet and my numbers are low. But how can I be sure that that yellow is gone down? What is the
Yeah.
mechanics? I'm
So you
looking
don't,
for the
yeah.
mechanics.
So you don't necessarily, so a couple of things. On average, significant change in diet will reduce the amount of cholesterol in these plaques by about 8%. So it's not a significant reduction due to a change in diet. The thing that changes, I'm going to go to the next slide here and say the thing that changes is that when you change your diet, you change the composition of this plaque. So even if the plaque is the same amount, but if the composition of the plaque is less anger forming, if you will, that reduces your risk of heart attack. So the two things that happen when you change your diet, or when you start exercising more, or you start taking a statin, those three things will do this thing. The first thing that happens is this layer on top becomes thicker. So it thickens the fibrous cap on top of the plaque. And the second thing is that you get about an 8% reduction, primarily in cholesterol of the yellow portion inside. And so as a result, what happens is it's harder for that plaque to rupture. And if it does rupture, the stuff that comes out is less angering for the body. And so I hope that the biggest thing that you get from this is, in the absence of symptoms, the anatomic amount of narrowing is not that important. Because I have patients that have 95% blockages in multiple arteries, and they are running, and they haven't had bypass for one reason or another, and they are running. They're doing activity and exercise. They're asymptomatic. They're managing their risk, because the main thing is plaque stability in terms of reducing your risk of heart attack. Does that answer your question?
Yes. So basically, you're saying yellow doesn't reduce necessarily. It's just hard to get into the part that is not supposed to get in.
That's right. Exactly right.
Okay. Yep. And second question is about the food, because that's what I was experimenting with. So food, how does that really work? And that is also related to South Asian diet. For example, say, once a week, if I do fast, is it like I understand the per meal restriction is really good. So that's ideal situation. That's not me. I have addiction to food. And if I'm stressed, I will eat food. But when I calm down, if I do a fasting, controlled fasting, not like fast, but will that like average out, or yeah, I'm done the damage, you're out of question, because I can't really control my stress bouts, and I have come to kind of realization with that. Okay, I really cannot do it. So what's the alternative?
So a couple of things. So the fasting periods over a course of the week probably is not that helpful. Like if you're doing fasting once and then you're eating terribly the rest of the week, you're already creating a lot of atherogenesis. And so the one day of fasting probably is not. But thinking about food as not in a single meal, but over the course of a day or 2 days is probably reasonable. And so the way that I talk about when you're just starting to change your habits on eating, especially when there is an external driver for your eating, what I say is like, think about the total amount that you intake in 1 week and try to manage the week at first and allow yourself control over, say, 5 days of the week, and in 2 days, give yourself one cheat. And then try to shrink it to 1 day, one cheat, or do one cheat a day so that you can manage your energy over the course of the week. So, if you flip the question you're asking on its head and saying, if I'm good 5 days a week and I cheat 1 day a week, is it equally bad? The answer is no, it's actually great, because 5 days a week you're doing really, really well. So I think that what I would do is I would start by, here's the amount that I'm eating in a full week. And here's the components of the food that I'm eating in a full week. And here's what I'm going to allow myself to cheat. So once a week, I'm going to have that, samosa, because I really want that samosa. Once a week, I'm going to have something that I really want. I'm going to look forward to having it. But what that does mentally for you is it allows you to sort of restrict a little bit. The most important thing to remember about change in diet is the change in diet should be something you can do forever. I have lots of patients who have an event, or they have a brother or sister who've had an event, and they say, I'm going to change my life completely. And they drastically change their life for 6 months. And then they drift back to what they were doing before, because the incremental change is really what's sustainable. So I'd say that a cheat or 2 cheats, or if you need 4 cheats at first and try to shrink them over time, that's okay. But you really want to sort of say, over the course of the week, I'm really going to try to do this most of the time. And then you were asking about did you say something about the vegetarian stuff? Did you ask about that?
Yeah, I think many people have asked that question. If you can quickly
हे
go
काय
a
माझं
little
गेला
bit
कसा
about vegetarian diet and also low carb diet that you mentioned.
Yeah. So I want to be clear that
काय
low carb
झालं
doesn't mean no carb, right? So I think you can have a carb diet that's, again, remember, if you take all the calories you eat in the day, all the food that you eat in the day, if you make less than 50% of it carbohydrates, you're in good shape. And so that's sort of the first thing that I would think about. In terms of a South Asian vegetarian diet, there's actually there are 2. So the Masala study, if you Google Masala study, they actually have a diet plan. And then the Palo Alto Medical Foundation, PAMF, has a South Asian diet plan as well that they've had for years. So there are resources that give you details. But just to think in principles, the main things that we want to think about if we're having a South Asian diet that is vegetarian, how do we balance? The main thing is to think about what are the proteins and the fats that we're going to eat or we're going to incorporate to reduce our appetite. That's because if you're only eating vegetables, then so I think that the proteins like dal, like eat dal in every meal. It's fantastic, really, really high protein, very little anything else, right? And so it's probably one of the lentils and beans are probably the 2 biggest opportunities for us that we're ahead of the curve, because that's in our diet already. The other thing is that focus on green and colorful vegetables. I think that when you're eating vegetables, like sticking to potatoes are a high carbohydrate vegetable. So switching from potatoes to things like peas and carrots and spinach, those sort of colorful vegetables, I think that's a good shift to make. And then in terms of the carbohydrates, make your carbohydrate budget at the beginning of the day. I'm only going to have 2 rotis at dinner time. I'm only going to have 1 cup of rice during the day, and then allow yourself, based on what the day is, to sort of say, okay, well, at lunchtime, I'm going to have lunch with my kids or my family, and I want to have my carbs then. So really just budget the carbs throughout the day like you'd budget your finances. And I think that then you'll get to the right place.
Great. We only have few minutes left, so we are just going to quickly take some questions, but I would request everybody to be brief. Rekha Tai, you had your hand up. Do you want to go next?
पहिले एकच क्वेश्चन होता की टोफू इज गुड फॉर टोफू
Tofu is a great question. So tofu is a high protein, low everything else. So it's like dal. It's excellent to use. If you know how to cook with it, it's a really, really good option. And it's actually it's satiating, so it'll fill you up. So it's really good. Yeah.
रेखाताई बोला.
माझा प्रश्न नाही आहे खरं म्हणजे
पण you had really good information, and I wanted to say that I belong to masala study. I'm in Chicago area, and through Northwestern University, I belong to the masala study. Last year, I had all the tests done, and fortunately, my tests were not negative or bad. So maybe that's why I did not get any diet or anything information. But do they give information about the diet in to lower the
Not if you're,
carbohydrates?
yeah, not if you're a participant. So the study itself is like a research study, right? So it's meant to study your parameters over time. So thank you for participating. It's a really important study for South Asians. But the website of the Masala study has diet suggestions. It's sort of part of their work. The other one is in Northern California, because there are so many Indians in Northern California. I think that there's a lot of South Asian focused resources, especially on diet and nutrition. So I have one that I've made myself. It's a little outdated now because I haven't updated in a while. I'm happy to share, and you guys can take it and do what you want with it. But again, it hasn't been updated in about 5 years. But the Palo Alto Medical Foundation does a great job of updating theirs.
Yeah,
Yeah.
we would love to, share that with the whole group. We have a WhatsApp group, so if you share it with Alka, then we can share it with the group. One last question, Uma Tai.
Okay, my question is that if person has a high blood pressure, but angina and AFib, can you hear me?
Yes.
Okay. And he is taking Eliquis as a blood thinner, but unfortunately he has bad arthritis too. So in that case, what medication he can take to lower his pain because of the Eliquis has some kind of a reaction with interaction with other medicine. So is there anything you can suggest that how he can balance all those things together?
I'd rather not give individual medical advice on these kinds of stuff because there's so many subtleties to an individual medical condition. It's a good question to ask your cardiologist. I think that it's a complicated answer actually, but it's probably not best to. I don't know your whole medical history. It sounds like it's a specific question about somebody, so I'd rather not give individual medical advice.
Yes, definitely. We always have a disclaimer at the beginning and end of sessions like this that, all the information that was provided was for information purpose only. So whatever personal questions you have about your personal health, please make sure you talk to your doctor before you make any changes or take any medications. So Dr. Ameya Kulkarni, thank you so much. This was a very informative session. And I'm sure people have a lot of other questions because I'm still getting questions in the chat. But we have a WhatsApp group and we will put the recording on that. And we have a YouTube channel. So the YouTube link is shared with everybody so they can revisit this information. And if they want to contact you or get information, is there like a place where you can be contacted or your website or whatever it is? They would love
Sure.
that.
I can put my email address in the chat. That's probably the quickest way.
Yes.
Yeah.
Okay.
I can't give individual medical advice. Wouldn't want to.
Yes.
But I think that certainly general questions I'm happy to answer. And then if I can just answer one question, there was a question about meditation and risk of heart disease. Can I just answer that question to close?
Yeah, sure.
I think that's for this group. It's a good question to answer. So interestingly, like the data on meditation and heart disease is poor. It's not good data. It's sort of clear. There's a lot of bias in the data, but I would say that what we know about stress and its relationship to heart disease or coronary disease in particular is we know that a baseline medium amount of stress is probably not harmful and may be protective. That like brief stimulus that you get may be protective. And we know that surges of stress are potentially damaging. The way that I think about meditation or yoga or pranayama in that context is that it reduces the spikes, right? And so that's its whole intention, is to reduce the sort of spikes of stress and reduction. So there isn't anybody who tells you there's good data to support its use. That's not truthful. There's not good data to support its use. The data is poor and biased. With that said, practically speaking, it's an intervention that has very little downside and a clear biological plausibility, right? And so if you ask me how I recommend, I say anybody who wants to do it should do it, because in theory, if you can reduce the spikes, we know the spikes are associated with higher risk of heart disease. So if you reduce the spikes, you should make things better. But I think that so I would strongly recommend it. But the only caveat is don't make it your only activity. It doesn't replace cardiovascular exercise. You still need to walk, run, bike, swim. So yeah.
Yeah, I think that's a great message to end this session on.
Sorry, I had a question you skipped. Like I had asked in the beginning, it was important, and we are talking about food and HDL and everything. But there is a critical thing, because I have personal experience, that is about a rupture. We have not talked about like what we do to prevent. Sorry to interrupt, but I had asked a question earlier and nothing has been talked about it. So if you don't mind, please, for a minute, because that's a common thing. Anybody doesn't have a calcium score or anything like that, they eat proper food, even with small thing, the rupture can happen. So
you're talking about a plaque rupture, as in
Yes.
a heart attack?
Yes, correct.
Sure. So we did talk about that about halfway through one of the other questions. So the major ways to reduce a plaque rupture is to thicken the fibrous cap and reduce the amount of cholesterol in the plaque. And the way you can reduce those two things are with diet, exercise, and statin. Those are the three things we know have reduced the likelihood of a rupture happening. In the event of a rupture, a baby dose aspirin does reduce the sort of intensity of the heart attack, but for primary prevention, people who've never had an event before, the data on whether aspirin is helpful is mixed, and so that's a conversation everyone should have with their doctor, because it's an individualized conversation now. Whereas before we'd say everyone should get aspirin, and now it's more subtle than that. And so I think that's a conversation we'll have with the doctor.
Thank you.
Is that a satisfactory 1 minute answer?
Yeah. I wish, we had more time, because I'm sure everybody has so many questions, but thank you so much for giving us your valuable time and expertise. It was really
pleasure.
nice
Thank you.
have
Take
you.
care, everybody.
Thank you.
Thanks.
Thank you.
We are going to now, before we end the session, generally we talk about what the next session is going to be. तर पुढच्या आठवड्यात जे सेशन आहे त्याची माहिती आपल्याला सबनीस काका देणार आहेत. सबनीस काका?
Hello, namaskar everyone. Ameya, thank you very much. Your dad attends the pranayam classes regularly. You probably know that. This is changing the topic. Tomorrow, next Sunday, we have session by Ramesh Wagmare, and there will be some part by his wife Mangal Wagmare, and both have hosted many classical musicians. So his talk is going to be about Bharat Ratna,
Pandit Bhimsen Joshi.
Bhimsen Joshi. And he's going to talk about the man, his music, and spirituality. That's the topic.
Great.
They know him personally, and they have known him personally, and they have many times they have hosted his programs and so on. So it will be more a personal level information about Bhimsen Joshi.